I have my other one that's back here, the 12th edition one.
Oh, good.
It's mainly the same, like I'm so sorry.
Welcome to our second class at COS EMT. Happy to have all of you here. My name is Brian. I'll be your instructor for tonight. We're going to go over medical and legal ethics, medical and legal and ethical issues of EMS. But first, start with our thought for the day. Preparedness makes a difference in a split-second decision. You will perform the way you train. If you train and you do a half-ass job training and you screw around, when you have to make an emergency split-second decision under stress, you will perform exactly the same way you train. If you're diligent, you're training consistent, do it again and again and again professionally, and put effort into it, your muscle motor, when you go into fight or flight for having to save someone's life, you will do exactly as the way you were trained to do. Because you won't even have to think about it. That's what preparedness is. Knowing your equipment is ready and knowing how to use it without thinking and being able to do things automatically is critical to success in a time-sensitive situation. Any questions? The only way you get that way is by practice again and again and again, doing the same repetitive things. Any questions? All right, so we're going to learn about tonight. We're going to learn about consent. We're going to learn about the different types of consent, defining the meanings of consent, going over the steps of refusal of service, defining HIPAA and what it is. Everyone loves HIPAA. No one ever. Accurately describe a DNR or an advanced directive. And we're going to go over the physical findings and the presumptive findings of death. Any questions? All right. Describe what a medical alert signal is. Understand duty to act. You have to know that one. Absolutely, because it's the building blocks of a lot of different things. And you're going to have to understand what the difference is between negligence, abandonment, assault and battery, and kidnapping. And you're going to be a mandated reporter as an EMT. So you have to understand situations that require special reporting. Any questions? All right. Consent. You are not allowed to legally treat any patient unless you have obtained consent. There are 4 different types of consent. You have to obtain one of them. The most common is expressed. Hi, my name's Brian. I'm a paramedic. College of the Siskiyous. Can I treat you? That's expressed consent. Now, let's say they're unconscious. They can't answer. It's implied that they would want you to help them because they're unconscious. So they don't have the ability to tell you or the ability to give you consent. That is implied consent. Next one is informed. Informed is consent in writing. As pre-written directions. For instance, when you went to school, you set to bring home the packet for your parents. If you had to go on a field trip or if you did sports, the parents would fill out the consent. That's informed consent. Same thing with an advanced directive, a post to living will, which we're going to go over today. Those are all types of informed consent. The last one, involuntary, you guys as EMTs can't do, but law enforcement can. You have to call law enforcement, and only law enforcement can do involuntary consent. And that is when someone is a danger to themselves or others, or gravely disabled. Or refusing, they can place them under what's called a 5150 hold. That is involuntary consent. Any questions? Yes.
Police and others that can do the involuntary. They don't legally have to.
No, they don't have to. It's their decision. However, if they don't, then you document their name, agency, and badge number, and you put it in your report with an excellent, clear description of what the scene was and why you felt it was needed. Then it goes to court if something happens for negligence, then it goes back on them. That's how you handle that. Exactly. So express consent. In order for someone to give you express consent, they have to be a legal adult. They cannot be a minor. They also have to be oriented a person, place, time, and event, and intellectually capable of making an informed decision. Any questions on expressed consent? Here's an example of express consent.
Express. Thompson.
Any questions? All right, so now we're gonna go over implied consent. Come on. So again, so the patient's not capable of making a decision, they're unresponsive, or it's a minor with no guardian present. Implied consent. All. All you need. Any questions on implied consent? All right, informed consent. Again, this is pre-written construction instructions like a permission slip. Any questions on informed consent? I don't know how Jake became a female and then back to a male, but it happened.
Sarah went back to the mail in like 3 different flip flops.
I know. It's amazing.
And they were treating a severed leg too. I don't know if you noticed that.
Yeah, you know, we're getting there. So involuntary consent. So there's a couple of different ways to do an involuntary consent. There's 5150, which is not in scope practice. And that's again when someone is determined to be a danger to themselves or others or gravely incapacitated. and puts them on a 72-hour hold by a law enforcement, usually in conjunction with BHPO. That's Base Hospital Physician Order. And there's two other ways it can do. Another one is 5170. 5170 I've never actually seen used. That is someone that is a danger to themselves or others, or gravely incapacitated due to alcohol or controlled substances. Whereas they probably wouldn't be if they were sober. Generally, in that case, law enforcement prefers to use 647F, which is intoxicated in public, which is much less paperwork. So they just go to jail. Any questions? Here's another video. Now here's something we hope you'll really like.
After a third.
Any questions on involuntary consent? Moving on. All right, emancipated minors. 99% of minors claim to be emancipated are not actually emancipated. They read about it on TikTok or something. Just because they're not living with their parents does not make them emancipated. If they are truly emancipated, they'll have their paperwork, they'll be educated, and they will be able to show you that they are emancipated. Any questions? They'll have their legal court orders with them. Yes.
Are you actually allowed to ask for that paperwork, or is that against the law to ask that?
God only knows today's laws. I have no idea.
Figured I'd ask before I actually
That
got
would
into
be
that.
in your state laws. I'd have to go back and review the protocol because it changes all the time. I actually don't have an answer to that. I'll have to look it up at break time. It differs from state to state. In California, you probably can't ask. So, all right, refusal of treatment. Again, you'll have a local protocol on refusal of treatment, but the general basics of refusal of treatment are pretty much the same throughout most EMS systems with a few differences here and there. Generally, if someone wants to refuse treatment, if they're not willing to give you consent to treat or transport, they have to be a competent adult and aware of the consequences or the potential consequences of not receiving treatment. They have to have a significant medical concern or mechanism injury. That's what MOI stands for, including any advanced life support chief complaints, chest pain, possible stroke, respiratory distress, things like that, altered level of consciousness. You have to not be okay with the refusal, and you should always make base hospital contact and speak to the mobile intensive care nurse or physician on duty and see if they can talk to the patient. Those are the basic steps for someone to refuse treatment. And in most places, you're going to have a checklist like this that you go down to make sure. Now, sometimes you're not able to get through this checklist because they'll just walk away from you, which they have every right to do. Any questions? But you should try to do a physical exam of vital signs, do a complete assessment, and then give them medical advice on what you're concerned about, what the benefits of treatment are, what the potential risks of not having treatment are, and the potential things that could lead up to and include death. And then make sure that they have a full understanding of the benefits and the potential negative aspects of refusing treatment and the benefits of receiving treatment. And then make base hospital contact, let them talk to them, hopefully. And if all that's done and they have a clear understanding of it, then you have them sign what's called an against medical advice form. Then you document it in detail on your patient care report, because it is the number one litigated thing in emergency medical services is refusal of treatment. They refuse, then something very bad comes out of it, and then they try to sue you for not treating, even though they refused. That's why you have this checklist and why documentation is critically important. Any questions? All right. So when do we get law enforcement advised to take them under involuntary consent as opposed to allowing them to sign against medical advice? Well, anyone that's severely altered and not capable of refusing, anyone that voices self-harm, anyone that's being clearly irrational, if they are a minor And if they are, well, they're already under a 5150 hold by law enforcement. Law enforcement doesn't assist or tells you that they don't want to. That's when, as we said before, you have then speak with the base hospital physician. You document their agency name and badge number, and then move on. You cannot take anyone against their will. Any questions? HIPAA. The Health Insurance Portability and Accountability Act, 1996. So HIPAA started out, the president's wife, first lady, came up with this great idea in the early 90s. Her name was Hillary Clinton. That they're going to do it. Health insurance for all people. It was going to be a one-page form. That's what this was. The Health Information Portability Accountability Act. And everyone's going to have the same insurance, and everyone's going to be able to afford it. It's going to be a one-piece document. That's what it was. Well, by the time all the politicians got together, negotiated, the lobbyists got involved, and they got done with everything, nobody got health insurance, but they took the existing privacy laws and gave teeth to it. So they started fining people and having consequences if you violate a patient's privacy. So if you violate a patient's privacy, you're up for a $5,000 fine for each occurrence and removal of your license or your certificate. And I believe a $15,000 fine for whatever agency it is that you work for each occurrence. You're not allowed to give any of the patient's information unless they sign a release. Can't go down to the bar after the judge says, well, you should have seen what happened to Joe Smith. Oh, he did this. Can't do that. Also can't take pictures, post them online of people. No. Cannot do that. Also can't take pictures and send them to your friends of someone. Patient. Any questions? Yes, all those things have happened many times. There's a lot more information on it. It's not very attractive or exciting. Any questions? You also have to advise the patient of their HIPAA rights. And you're supposed to get what's called a HIPAA signature after every patient contact, usually built into your PCR form. Any questions? Yes.
I know for the billing and medical and record side of it, that's what I do. But on a call, if you are helping a patient and the family is asking about their information, you still can't release that to the family.
That's correct.
Okay. They have
Correct.
to have verbal consent.
Get that consent from them. Yep.
All right. Making sure because the family's right there.
Yep. That is correct. Any other questions? Everybody loves HIPAA. All right, social media. People love to post on social media. You have to avoid agency logos, uniforms, markings. Not take pictures of patients. You have to be professional. Can't take pictures of patients' families. And free speech is a thing. It is true. You have every right to free speech. However, you are not immune from the consequences of free speech. Does that make sense? So just because you have the right to say something, you can't be prosecuted in a court of law. However, your employer does not have to continue to employ you for what you said through free speech. Make sense? Any questions? Oh boy, advanced directives. All right. So advanced directives take many different forms. An advanced directive is a pre-written set of instructions for what you would like to see done if you are incapacitated. You cannot tell a healthcare provider what you would like done if you are incapacitated. They have things called living wills, healthcare directives, PULSE, which is a pre-hospital order for life-sustaining treatment. They come in many different forms. There's DNRs, which are do not resuscitate orders. People that don't want CPR, they can fill that at any time. And that only kicks in when, again,
they have no pulse and they're not breathing. Just because they have a DNR does not mean that you can't treat them up until they die. Any questions? There's some examples of what advanced directives look like. Any questions? So pulse, position order for life-sustaining treatment. Sorry, I said pre-hospital. It's actually position. Or medical orders for life-sustaining treatment, which is a MOLST, give you much more detailed instructions and often are not filled out correctly, which makes it very difficult on scene. And also there are things called durable power of attorneys, DPAs. That's when people sign over if they are incapacitated or can't make decisions. They give this other person legal authority to make their medical decisions for them, often children and spouses. Any questions? Again, do not resuscitate does not mean do not treat. It just means if their heart stops and they stop breathing, you don't do CPR. You still do everything up to that point. Now, if they're on hospice, which is also known as palliative care, there may be a whole separate thing involved there. You should have a hospice protocol. If you know someone's on hospice or they tell you they are, the hospice nurse should be contacted, because if they use 911, there's not supposed to be heroic measures involved. Palliative care, in other words, no EMS. But sometimes we get called anyway because people don't understand. And then it should be up to the patient and the hospice nurse if they want to go off a hospice or stay on hospice. But generally, if you take them to an emergency room, they're going to lose all their hospice benefits because they're no longer going to an emergency room would not be palliative care. Palliative care is to make you comfortable. You understand you're going to die. There's nothing saving you, so you want to die comfortably. To go to the emergency room is not considered part of that. Any questions? All right. Yeah. You guys are going to encounter a lot of death working in emergency medical services. The physical signs of death: no respirations, no circulation. That's the physical sign of death. They're not breathing and you can't find the pulse. A presumptive sign of death is no pulse, not breathing. Pupils don't react. They're turning blue. Touch. Definitive signs of death, that's when you don't start CPR if they have definitive signs of death. That's when the heart, lung, or brain is removed from the body. It's not survivable. They have dependent lividity. That's interesting. Dependent lividity is when all the blood is pooled to the lowest gravitational spot. So you'll see it's called a demarcation line, and I should have pictures in here of it. And they'll be purplish black colored on the lowest part, and then a demarcation line, and everything above that is pale. That's because their heart hasn't been beating and all the blood flows down to the lowest gravitational point in the body. And then rigor mortis, that's when they're stiff. And rigor mortis generally starts in the jaw. So if you can't open their airway because the jaw is stiff, that's rigor mortis. You don't do CPR. You don't tell the medic their jaws seized shut. Their jaws, dead people don't have seizures. They're dead. If their jaws seized shut, that's rigor mortis. Any questions? That's dependent lividity. They roll her up onto their side. See the handprint for the guy underneath their back. That's what dependent lividity looks like. All right, so if you're not going to do CPR on someone, if there's a physician that's willing to sign a death certificate, that's cool. They can do that. But if there's not a physician willing to sign a death certificate, they become what's called an ME case, medical examiner's case. They're going to take them in, do an autopsy, cut them up, find out why they died. Any questions? There will be test questions on organ donors. Organ donors are never treated differently than anyone else. Make sense? You got to do CPR because they're an organ donor. Definitive signs of death is definitive signs of death, those organs are dead. No benefit. Did we already do this? Oh no, I think I messed up here. Interesting. Put it in twice. All right, standard of care. So federal, remember, National Highway Traffic Safety Administration and Department of Transportation, they're the ones that set the very, very basic framework for an EMS system. Then each state develops their own EMS system. There is no federal EMS system. And then within each state, each medical area, like California, it's broken down by counties. Some states that are smaller states, it's good across the whole state, but you have what's called a local scope of practice. And that's what amount of care you're allowed to do. Any questions? All right, you guys ready to learn about this? There's gonna be a lot of test questions. Duty to act, you have to know. It's an important component. So if you are on duty working for an agency, you have a duty to act if you are dispatched. If you are not on duty, you do not have a duty to act unless you offer someone help. If you are not on duty and you offer someone help and you make patient contact, then you have a duty to act, and you have to stay with that person until you can turn them over to someone else of equal or higher level care. So if you're driving home from work and you're off duty and there's a car accident in front of you and you stop to help, then you have a duty to act. Or if you're in picking up a cheeseburger at a fast food place and someone's having chest pain, you say, I'm an EMT, can I help you? Then you have a duty to act. But if you don't offer and you don't make contact and you just keep going about your business, you do not have a duty to act. Any questions? So duty to act is the core founderstone of being able to prove negligence. Negligence is hard to do, especially gross negligence. You have to work really hard to be negligent, real hard. But it is still done on a regular basis in EMS, which is fascinating. I even have some videos that if I didn't show them to you, you wouldn't believe me. So in order to be convicted of gross negligence, they have to prove 4 things. 1, you had to have a duty to act. There was no duty to act, there's no gross negligence. So you had to have a duty to act. There has to be a breach of duty, and they have to prove that you breached that duty. You had a duty to act, and you didn't do what you were supposed to do. There has to be damages. Something bad had to happen. Something had to go wrong. Something happened to that person because of that. Then they have to prove that the causation of those damages were from your breach of duty. Now, you would think that's hard to do, but yet every day in the United States, negligence happens. We're going to hope that you guys never do that. Any questions on the 4 things it takes? So we have lots of test questions on this, on negligence. All right. There will also be questions on abandonment. Abandonment is a form of negligence. That's when you terminate care to a patient before you turn them over to someone of equal or higher level of care. That's abandoning your patient. This video is hard to watch, but you need to watch it. This is one of the worst cases of gross negligence I've ever seen in my life. This is a paramedic that obviously has burnout. She's in prison now, so is her EMT partner. But here it is. An 8-minute video.
Get up. Now. I am not playing. Seriously, not.
That is not how you actually get a patient.
The 10 feet. 10 feet, my man. Come on. I want to be in guys. That's what he does. Slams him face down the gurney, speckles him up. Never takes vital signs. That was odd.
I thought you did.
I didn't do that. Dose. Brought him into the hospital, discovered he was dead. So did they have a duty to act? Absolutely. Did they breach their duty? Were there damages? Yeah, that's pretty good damages. Can you prove that the damages were caused by their breach of duty? Absolutely.
They're in prison now, where they belong. He died.
He was complaining of shortness of
He's
breath.
having
They
a
didn't-
heart attack.
They didn't take any vitals, they didn't do anything
No.
except yell at him. Right. And drag him out of the house.
This is another one.
So this one, the guy's cuffed up on the ground. They call for EMS and EMS shows up, puts the equipment down, then goes over and talks to the console. The guy stops breathing. So there he is, he's down. EMS steps over him, never step over your patient, that's a critical fail. They waited like 40 minutes on scene, did nothing. The guy died. So they didn't do anything, so did they have a duty to act? Yeah. Did they breach their duty? Yes. Were there damages? Yeah. Were the damages caused by their breach of duty? You wouldn't believe it if I didn't show you the videos. It's unbelievable. All right, abandonment. That's when you have made patient contact and then stopped contact and just left them without turning them over to an equal or a higher level of care. That is a form of negligence. Unless, of course, they refuse treatment, got them to sign.
So if paramedic was to go to see the patient, but the crew of EMT showed up to transport that, would that be counted as
Yes.
abandonment? Because he's a
It's not
higher
an
level
equal,
of care?
exactly. They cannot hand down care.
Unless they have a pre-approved protocol for it. Even then, they're still responsible for it. Here's a great example of abandonment. Any questions? That's how abandonment happens. Best of intentions. All right, assault, battery, and kidnapping. So the definition of assault is not what most people think it is. It is putting someone in fear of immediate bodily harm. That's what assault is. Battery is when you actually touch someone or hurt them. Kidnapping, placing someone or carrying them away or abducting them against their will, or confining them against their will. Questions? All right, so as EMTs, you will be mandated reporters. Meaning by law, you have to report things when you see flags. You have to remember, as a mandated reporter, you're not accusing people of anything. You're not the judge of the jury or even the investigator. You just have to make the report so it is adequately investigated in case there is something there. So things that you have to report that there are signs of child abuse, elder abuse, childbirth, death, sexual assault, anyone injured during the commission of a felony, anything that's related from illegal drugs, crime scenes, dog bites. Apparently dogs aren't animals because animal bites are in a separate category. Gunshot wounds, which is abbreviated GSW, stabbing, or any other type of battery, not assault. Any questions? So, as an EMT, you may get called into court as a witness. You should always notify your service director and any legal counsel if your agency has them. Now, your documentation is going to be critically important because when you get called to court, generally it's not right after it happens, it's years later. And you've probably done hundreds of calls since then. And you're not going to have clear details on what happened. So they're going to bring up your patient care report and they're going to throw it up on a projection screen like this. And they're going to ask you questions about it. So the clearer and more detailed and accurately documenting your patient care report is, the better you're going to be able to testify as a witness. If not, you leave things open for interpretation. Believe me, attorneys will do lots of interpretation of their own, make it to their own case. As a witness, you should always remain neutral and just report the facts of what you had. I strongly recommend you review your patient care report, your documentation before you go in there. Any questions? Now, if you're being sued or being charged, you should absolutely have legal representation. Questions? You threw a patient face down on a gurney and never assessed them and never took vital signs. They showed up dead. You're probably going to need an attorney. Yeah, nobody's got one that good. Discovery is what attorneys do. Do depositions, segregations. It's endless. You don't want to be a part of litigation. Any questions? Yeah, majority of court cases and lawsuits are settled in the discovery phase. When one side has more facts than the other, then it usually gets settled. If they can't settle it, then it goes to trial. Any questions?
So if you did gross negligence or did not provide the standard of care, you could be charged or you could be sued. So do the job and do it correctly. Real easy. Any questions? So ethics. You have to understand what's right and what's wrong. People do. You have to know your job, which we're going to teach you about in here. You will know your job by the end of this class. Absolutely. Code of conduct. You have to have good character, conscience, and you have to be honest and have integrity. And when you have a duty to act, you have to assess your patient, do the correct treatments, transport your patient, and be professional. Any questions? Nothing scary, nothing hard about it. Just be ethical, be professional, and just be a good person. It's about your patient. It's not about you. Any questions? If you're bringing patients' belongings with you, like that bag there, always document what you brought and who you delivered the belongings to. That way, if something comes up missing and they accuse you of it, you have a documentation trail. Any questions? There's a little checklist for you on ethical decision making. Is it about your patient? Is the decision being made on logic rather than emotion? Does it protect the patient's rights? If it was you or your family as a patient, would you agree with what you're doing? Would you make the same decision again in the same circumstance? And can you defend the decision to others? If it's yes to all those, you're good to go. Any questions? All right. Let's move on to the next chapter. Ta-da! Any questions on legal and ethical? Yeah, not right. Oh my goodness. Big yawns. All right. Communication and documentation is critically important. But let's do a thought for the day first. Life is never easy, and things rarely work out the way we think they should. And it's easy to get lost and frustrated, chronically disappointed because of that. It's real easy. So how do you get successful and happiness when things are always going wrong and things never work out the way you think they should? How do you do it? What you do is you learn from the disappointing outcomes. You build a better plan for the next time you're in that situation, so you end up with a different result than what you got this time. If you do it the same way, make the same choices, and take the same actions, you'll get the same results. If you learn from it, do something differently, make it better and improve, you get a different result. How you do that is through positive attitude, positive actions. In the long run, you'll make baby steps forward, and your life will get easier and things will get better. Paying a small price and a little extra work in the beginning pays big dividends in the end. Any questions? Shortcuts usually end up to undesirable results. Almost always. Do things correctly, do them right, do it how you're trained to do it. Any questions? All right. So what are we going to learn about? We're going to learn about the importance of good communication. And we're going to learn and explain techniques of good verbal communication. Understand the barriers of communication. We're going to go over how to write patient care reports and the legal implications of patient care reports, which is abbreviated PCR. We're going to go to the different types of equipment in communication. Proper ways to communicate on a radio. We're going to go over why patient care reports are so important. Any questions? All right. If you can't communicate with your patient,
Doing a good patient assessment is going to be extremely difficult. Things that can block it, age, culture, dialect, language, all those things can have effects on your communication with your patient. However, your facial expressions, your attitude, your body language can make or break your patient assessment, your communication with your patient. Any questions? All right. Always trying to make eye contact with your patient. Introduce yourself, who you work for, and your level of training. When you ask them a question, give them time to answer your questions, especially if they're elderly. They have the tendency to think about their answers, just blurting out the first thing that comes out of their head like I do. Any questions? People can sometimes become hostile towards EMS clinicians. You can use the stamp mnemonic to see if they're going to potentially be aggressive. They're staring, their tone of voice, their anxiety level, mumbling and pacing. All signs that they may become agitated, may become an aggressor. Any questions? The big thing is to diffuse the situation if they meet that mnemonic. Make sure you have backup. Get law enforcement if you need it. Minimize distractions. Only one person talks to the patient. Speak clearly, concisely, and calmly, and be non-confrontational. Always leave yourself an escape route in case things do deteriorate. Make sure you understand what the patient wants and needs. Don't use threatening body language. Don't be dishonest with the patient. Be honest and orient them at all times. Any questions? All right. So communication techniques, facilitation, pause, reflection, empathy, clarification. Don't do confrontation. Always explain what you're doing and why you're doing it. Always summarize what your assessment is, what you feel the primary impression of what's wrong is, what your treatments are. Any questions? Consider use of touch. Some people don't like to be touched, so make sure you ask before you touch anyone. Any questions? I have nothing to add to that. Never, ever, ever give false assurances or reassurances. Don't ever say something is okay when it's potentially not. Don't give unsolicited advice. Don't ask leading questions. Don't interrupt your patient and don't speak in jargons. Your patient's probably not going to understand that. In EMS, we have a lot of jargons and code words, things that we talk to each other about. That's not appropriate to talk to the patient. Make sense? Any questions? So there's often going to be family and friends and bystanders on scene. They're all going to be filming you. Lay it upside down. I've been on scene and noticed sometimes up to 3 to 4 different cell phones recording us on scene. So be prepared for that. You're going to be recorded. It's legal for them to record you. It's not legal for you to record them. Friends and family can be valuable, and they can also be a distraction. It just depends. Don't be afraid to ask bystanders for help if the patient's not able to give you the appropriate or correct answers. And if they're helpful with care, use them. If they're hindered with care, try to distract and divert. Any questions? Make eye contact with your patient. In some cultures, that's not appropriate, but again, use your name, agency, level of training. Always be honest. Always orient the patient to what you're doing and why you're doing it. And if it's the language barrier, you're going to have to get an interpreter, use Google Translate if you have internet, and figure out a way to make it work. Any questions? Always check your body language. Again, it can make or break your assessment. Speak slowly and clearly. If they're hard of hearing, make sure that you're speaking directly at them. Give them time to respond. And always be calm and confident. Any questions? Make sure you understand your emotions. Make sure you're defusing and not infusing conflict. Try to build a rapport, communicate effectively, and always manage the scene. Have to be able to manage the scene as a leader. And we're going to teach you how to do that. Any questions? All right. So they call this emotional intelligence. What the attributes of it: being self-aware, making sure you know what and why you're doing it, self-regulation. You have to be motivated, you have to have empathy, and you have to have good social skills. Any questions? The more you improve your emotional intelligence, the better your patient assessments and your patient rapport is going to be. Any questions? So the FBI developed the stairway model. Actively listen, make sure your empathy, build the rapport, make sure you have influence on your words, initiate behavior change. That's how you de-escalate situations. Any questions? That's the stairway to behavioral change. Person first languages. It influences how we think about our patients. If you don't use it, then you can negatively affect your relationship. Things like just saying things as simple as saying they're a diabetic, say this is a patient with diabetes. Then you're not labeling the patient. Any questions? All right, communicating with language barriers. A couple of things. Hearing impaired. You know ASL? Anybody here know ASL? Good job.
Yeah, a little bit. I don't know.
I don't. It's good in EMS. ASL is a huge, huge tool. And the other thing too is even if there's a different language, ASL still works. It also works very well with the hearing impaired. If you don't have ASL, if you don't know it, you're going to have to use written notes on a computer or a notebook. It's going to take you a little bit longer. Visually impaired people are more common than you think. For some reason, everyone in EMS thinks the visually impaired people are deaf, so they start yelling at them. I understand you're blind. Their hearing is just fine. It's their eyes. And of course, non-English speaking patients. You guys are blessed that if you have cellular internet, Google Translate is free, and it works incredibly well if you know the language that you're trying to interpret. If you don't know the language, great. I believe there are some AI ones now that
they start talking, it figures out what language it is. Just getting better and better and better. Any questions?
So as an EMT, you're also going to have to communicate with other healthcare professionals. And it's going to be crucial for survival in this system. You got to be able to communicate with other agencies, with other care providers, with hospitals, with firefighters, with police officers. You're gonna have to transfer that information. You have to give good radio reports, and you have to do good written reports. No one's gonna know what you saw, smelt, felt, heard, and did. Not able to accurately relay the information and have it documented in the patient's chart. It is critically important. Any questions? This is an example of how badly communications can go if you don't communicate well. There you go.
Any questions? Communication is critically important. All right, some things you need to know. 911, there's also 211 lines in some areas. Connects people with communities, essential community services that's not an emergency service. Any questions about the 211 line? All right, patient care reports. This is the documented what you saw, what you did, and why you did it. You're required to do a patient care report for any patient contact you come in contact with. That didn't make any sense. You're required to do a patient care report for any patient you come in contact with. It's important because you need to have continuity of care so people know what you saw, did, and why you did it. Legal documentation, education, administrative information, research to see what's working, what's not working. It's part of evaluation of continuous quality. Questions? It is imperative that you write a clear narrative of the events as they happened and what was done to help the patient. If you give a minimalist, unclear report, it allows for interpretation of things that never happened. You don't want that. They took away the greatest video ever. Oh, no. That was such a great video. It was KTVL of Medford. There was a cattle truck crash, and the newscaster was saying that the cows got out in black and Gus. And there's one black cow walking around, and he goes, "That's either black or Gus." And then the other guy says, "Or it could be Black Angus." Actually, that's what it said. It was the clarity of the documentation. How much younger she got? How much younger she got?
Any questions? That's exactly how you save lives with documentation. All right, so your narrative. Most EMS systems will, so basically the way a patient care report works is you put your patient information, their name, their address, their birth date, their medical conditions, their history, and all that stuff. Then you have a whole bunch of box checking for your administrative data for your state. Okay. But where the guts of the report is in what's called the narrative. And that's where you describe what you saw, what you found, and what you did and why you did it. So there's three formats that pretty much every EMS system accepts for a narrative. And they all ask to be written in one of these three formats. That way it's consistent and easy to read. So there's the SOAP format, there's the chart format, there's the chronological format. Okay? So we're going to go over what each of these are. So SOAP is a 4-part narrative: subjective, objective, assessment, and plan. So what is subjective? Subjective is the information you got provided you from dispatch and what the presenting information the patient and witnesses were at the scene. Objective is what you found, what you saw, smelled, heard, and felt when you did your assessment. And then assessment is the physical findings you actually touched and looked at your patient. And then the plan, what your treatment was, why you did the treatment based off the primary impression from your subjective, objective, and assessment. Any questions? And I'm going to show you how this works. First, we're going to go over the three types. I'm going to show you how the three different ones work and how it all works out. So the chart is similar to SOAP. It's chief complaint, history assessment, treatment, and transport. RX for treatment. That's a medical sign. So chief complaint is what the patient feels is the biggest problem. Then history is the documentation of what you found. OPQRST and sample are acronyms for how you obtain a history. OPQRST is your signs and symptoms. It's onset, provoked, quality, radiation, severity, and how long it's been going, time. And then sample is your signs and symptoms, your allergies, your medications, your past medical history, your last meal, and events leading up to it. We're going to teach you all that later. You don't have to know that tonight. And then assessment is the positive findings of your physical exam when you actually physically assess the patient. And then treatment, again, is the treatment protocol you chose and what you did based on the positive findings in the primary impression of your assessment. And then transport is where you took the patient to and why you took them to that facility. Any questions? All right, the last one, which is the one I prefer, is chronological. Chronological is very simple. Just everything that happens and everything that you did and saw and what you did at the time that you did it in a chronological order or format as the events unfold. Any questions? And I give you an example of this is the same call, it was an actual call, and I wrote you a narrative in all three formats so you can see the difference. It's the same call, same things are done, same outcome, but how the three different narratives work, three different formats for a narrative work. So you can choose which one works the best for you. There's an example. This is a 79-year-old male with chest pain. So here's the SOAP format. Subjective, dispatch to a man with reported ultra level of consciousness. En route, dispatch changes to cardiac. Objective. Patient presents sitting in a chair with complaint of chest pain provoked at rest at midnight. Unable to give quality, 8/10 severity, not radiating. It's been steady since midnight. Patient was waiting for pain to go away, but it did not, so he called 911. They did a 12-lead. We'll go over what STEMIs means after a midterm. It's a chest pain, heart attack event. Assessment. His Glasgow Cone Scale is 15. That means he's fully alert and already knows what's going on. His skin is normal, warm, and dry. His head, eyes, ears, nose, and throat are clear. He's got no jugular vein distension. His lungs are clear and equal to good tidal volumes. Abdomen soft, pelvis stable, extremities unremarkable. Plan. He was given nitroglycerin and aspirin without relief. Starts an IV on him, and nitro was not repeated due to the patient's blood pressure dropped.
And he was taken to the hospital, put in bed 8, report to Dr. Parker. Gives you a pretty clear picture reading that of exactly what happened and what the paramedic did, correct? So let's look at the same patient using chart. So chief complaint, chest pain, history. He presents sitting in a chair with complaint of chest pain, provoked arrest at midnight, 8/10 severity, not radiating, steady since midnight, was waiting for her pain to go away, but it did not, so he called 911. Assessment, top of the Glasgow Coma scale, normal worn dry skin, head, eyes, ears, nose sort of clear, no JVD, no jugular vein distension. Lungs are clear and equal with good tidal volume. Abdomen soft, pelvis is stable, extremities are unremarkable. And then treatment, patient was given nitro and aspirin without relief. IV was established. Nitro didn't go again because of a drop in blood pressure. Transport, we took him to the hospital due to being the closest and only facility in the region. Taken to bed 8 and report to the doctor. It's the exact same patient, but that's just a different format. But tells you pretty much the same thing, and it's still pretty clear. All right, last one's chronological. 18-15 hours, dispatched to ultra level consciousness. Dispatched advised en route. This is now cardiac. 1823, arrived on scene. 1825, 18 is military. Does everybody know military time? So it's 1 p.m. is 13. It's basically the hour of the day. This is like 6:23 at night. 1825, found patient sitting in chair with complaint of chest pain, provoked arrest. At midnight, unable to give a quality, 8/10 severity, not radiating. It's been steady since midnight. Patient was waiting for it to go away. It didn't, so he called 911. Aspirin administered, extrication begins, nitro given. Patient taken to the ambulance, also known as life support unit. Patient is in the life support unit, 1835. Patient is in the life support unit, so we're out to the hospital. Glasgow's 15, normal, warm, and dry. Head, eyes, ears, nose, throat clear. No jugular vein distension. Lungs clear, good tidal volume, abdomen soft. 12 stable, extremities are remarkable. No relief for the nitro or the aspirin. Established an IV, didn't repeat the nitro because the BP dropped. 1843, arrived at the hospital, taken to patient to bed 8, would report to the doctor and the MICN. So it's the same exact call, but that's how the 3 different formats go. You can use any of those 3 formats, and they'll give you a clear documentation of what you saw, what you did, why you did it. Make sense? So you can use any one of those 3. What's that? Yeah, tried to change the names to protect the innocent. There's an example of an AMA dispatched to a traffic collision with multiple victims. Arrived on scene, did the assessment, and then they signed against medical advice. They were a competent adult. They had a minor injury. They had a plan. They concurred. Here's another one. Heart attack. Patient was sitting in the passenger seat of a big rig truck. Assessed by a CHP paramedic. And it goes through the whole thing. Patient was called the doctor, spoke with the doctor. Patient states he understands the risks. And we allowed him to sign against medical advice because he's a competent adult. He had a significant complaint. The paramedic did not concur with it. Hospital was contacted. Risk of refusal were explained. Benefits of continued medical assessment were explained. Refusal of care was explained. He has a meaningful understanding of the risks and the benefits. He's agreed to call 911 if it gets worse. That way now, if this guy dies afterwards or has a massive heart attack because of cardiac cripple and tries to sue you later, you've got excellent documentation on what happened and why you didn't transport the patient. Any questions? Radio communications. So you have to know the difference between a base station radio, a mobile radio, a portable radio. A base station radio is fixed inside of a building. Usually goes to a large antenna on the roof and has major power, usually 30 to 500 watts. Mobile radios are mounted inside vehicles, ambulances, fire engines, patrol cars, and they're usually 25 to 100 watts. Portable radios, this is a portable radio. They're generally 5 watts. I don't think anyone makes 1 watt radio. And they're portable because you can bring them with you. Any questions on the difference between a base station radio, a mobile radio, and a portable radio? There will be test questions. All right.
So radio systems, so we test questions on this. The simplex, that's car to car, it's like a walkie-talkie. Everybody transmits and receives on the same frequency. So repeater based is different. So in a repeater based, let's say I'm on my portable radio and I want to talk to Wairika. 5-watt radio is not going to make it. Signal's not going to be strong enough to get to Wairika, right? That's why we use a repeater base, also known as a duplex system. So what it does is you transmit on one frequency. So let's say this is me here, my radio. Look at that smile. And then let's say the hospital or the dispatch center is here with its tower. So I can't transmit all the way up there. So if I transmit on a transmit frequency to a repeater tower, top of a hill, and then it takes my signal and then repeats it and blasts it back at like 500 watts on a separate frequency called the receive frequency, then the building or the people on the other side miles away can hear it. And then same thing, then when they talk back to me, they talk back on the transmit frequency, then it repeats it back to me on the receive frequency. It's called the duplex frequency because it's two frequencies, one for transmit, one for receive, and it gets repeated at a repeater. Questions? So this county is 6,000 square miles. It's got 8 different repeater systems for the fire net, depending on where you're at in the county. Any questions? All right, digital is becoming extremely popular. It runs over cell towers, or it can even run over regular towers. Digital, though, you don't hear any voice. It just sends it just like the internet, just sends it in bits of data. So all you hear is, but it actually comes up on a screen, on a phone, or on a laptop. And you can communicate back and forth. They can send messages. We get all of our dispatches now digitally. And we do it over voice over the traditional. So that way there's no way to miss it. And yet people still miss it. Any questions? So, how do you communicate? You're gonna have to communicate with dispatchers, you have to communicate with hospitals, and you have to communicate with other agencies. Did we already do this? I think we already did this. So again, the stairway model. We did this already. Any questions? All right, let's go to break, come back at 8 o'clock and be ready to go into skills.